Thank you, Rajarajan. Now let us all welcome Dr. Tushar, who has joined us with great difficulty in between his work. Please, Tushar, you can start. You can. Tushar, yeah.
Yes, so I wasn't sure what you wanted me to do because I have not prepared any presentation. So
yeah, I mean you're chairing this session where he was describing the mapping, and more than all that, I wanted to show off to my audience, Tushar, and and sort of uh, let you know that this is going on and how you should encourage.
Thank you so much, Bala, for inviting me. I mean, I know I goofed up initially. I mean, I got called into the ICU. This is a new service I have started here at Cleveland Clinic, where I'm helping out in the ICU with all tunnel lines. I don't put any non-tunnel lines, only tunnel lines in the ICU. And certainly this what you have started this forum, I think it's a great initiative to bring in the younger generations and also bring in the camaraderie of all the multidisciplinary people who are involved in improving vascular access care in India. And I think your forum certainly is unique in the sense that that it is interactive, and I think that really matters most, because as people start doing things and practicing on their own, there will be questions, and bringing in experts certainly helps answer those questions. So I was listening to Dr. Rajarajan's talk, and it was wonderful talk. So great presentation. And I'm happy to be part of this. Thank you again for this invitation. And I'm going to sit back and listen to the people who are going to present. And obviously, if there are any comments, I will certainly chime in between.
Yes, Tushar. To start, see this mapping and things which he was describing. Is it a routine practice in your place? Is all patients' venous mapping done? If so, who does the mapping? Is it the nephrologist or the radiologist or the surgeon?
So, yeah, mapping is done. Definitely, mapping is done. Again, different centers practice differently, but centers where I have worked, mainly the two centers at Wake Forest University and now here at Cleveland Clinic, we do the mapping. Mapping is done primarily by the radiologists, but the surgeons will always do it again in the operating room. And one point that Dr. Rajarajan mentioned, which I think is very crucial about tying a tourniquet and seeing the distensibility of the veins. I think that's a key point, especially after the regional block, when you see that sometimes the vessels that are missed by the radiologists often become significantly distended and are utilized by surgeons to create an AV fistula. So oftentimes when the patient goes in for to a radiology office to get the vascular mapping, they may be dehydrated, or a general blanket instruction is given to them, keep NPO. I mean, you don't need to be NPO for this. They come in NPO, they may be dehydrated, the room may be too cold. For whatever reason, the distal vessels may not necessarily distend as much. But once they are in the OR, after the regional block, after a tourniquet, the vessels distend, and the surgeons do find places where a good surgeon definitely will find a place where an access can be created. So yes, it's done by radiologists, but also reconfirmed by general surgeons or the vascular surgeons. Nephrology per se, we generally don't get too much involved here the way the system is. Most nephrologists are not doing AV fistula, so they're not, unlike what you do and a lot of nephrologists do in India. We do ultrasound of the access only after the access has been placed and either it's not maturing or we run into trouble.
Okay, I think that answers my next question was the likes of us who are doing AV fistulas here. I mean, aren't there much people there doing fistulas, nephrologists?
There are very few nephrologists doing fistulas, and again, those who are doing it essentially have had some surgical background from wherever home country they came in, so they are more comfortable doing it. Credentialing is a problem, and OR time is a problem. So certainly it's not, and yes, medical legal liability is a big issue too. So not many nephrologists. I can count a handful, no more than 10 probably in the country.
I see. Then when nephrologists are trying to do AV fistula, I think this mapping becomes very important because everybody is looking over your shoulder, how good you are, what is the success rate and all that. So the likes of us here in India who are trying to do fistulas, I think it is very important and imperative that we undertake mapping and things like that so that we don't get into trouble taking up cases which would not succeed. I think that was one reason this talk was chosen for today.
Yes, I think that's a great tool to have. Again, unlike here, I know there are places in India where people perform, the nephrologists are performing AV access surgeries in smaller rooms, not necessarily a big OR. So you have flexibility there, and if you have ultrasound is a reasonably cheap tool now, so why not use it and take advantage of that diagnostic tool.
Then Rajarajan, checking the blood volume flow, especially after the AV fistula, you should tell us where you do it. It's in the radial artery or in the brachial artery. I think that point should be told clearly to the audience.
Yeah, there are two ways of doing the blood flow volume assessment, sir. Pre-AVF mapping, it's not necessary to look for the blood flow volume. Actually, many studies didn't quote for that. That doesn't support the maturation of fistula. Only in case of access dysfunction or the maturation, assess the maturation, we need to do a mapping, the blood flow volume. There are two thoughts. One you can do with the feeding artery. Volume vessel, blood flow volume can be measured in the feeding artery. If you do a radiocephalic fistula, you can still measure the blood flow volume in the brachial artery because it's a good caliber artery. It is resistant for your compression compared to the veins. Because there's a diameter and radius is very important because of the Poiseuille's law. When you mistake the diameter radius, your velocity blood flow will go haphazard because it is a flow is directly proportional to the fourth power of R. So preferably artery is better to look for the blood flow volume measurements as against veins due to these constraints. I perform a blood flow volume on the brachial artery even if you do a radiocephalic fistula to assess the blood flow volume. Or if the radial artery caliber is good, you can do a blood flow volume assessment of the radial artery. If you want to do it in the vein, it should be in the mid, away from the anastomosis. That's the mid-arm vein where you have a straight, the vein course should be straight, it should not be tortuous, and there should not be any tributaries arising from the vein. You need to identify this area and to measure the blood flow volume. It's better to assess the volume in the artery. And there is a difference actually. If you have, we can have a differential diagnosis how to identify the problem with the blood flow volume. If you have the blood flow volume of afferent artery more than the efferent vein, there is a problem in the anastomosis. This is for a maturation of fistula actually. If your blood flow volume in the efferent vein is more than the efferent artery, that means that there is some amount of steel is going on. That means there is some tributaries going out and there is steel is going on. And if the efferent artery, efferent volume is less, very less, it means to say that there will be a both of artery and vein both are less. It means to say there is a problem in the central vein. So if your problem, if you are analyzing the blood flow volume for the access dysfunction, it has to be measured in the artery and the draining vein. If you want to assess for the surveillance purpose, it can be measured in the artery itself.
Great. And I think we'll have to mention here that the formula for calculating the volume is such that if you make small variations in the radius of the artery, that will make huge difference in the volume. So
Yeah.
one has to be very meticulous in taking.
Assessing the.
And any comments and questions from others? Dr. Velaravin, you want to add anything?
I'm perfectly fine with Rajarajan's talks. It's very wonderful. So actually, he covered everything. But one aspect I'm really worried, sir. In a patient's already on left side, a catheter already, patient is on catheter. That's why if you're asked to do a fistula, that's the issue always. The phasic variation, we can not only the central vein phasic variation. Sometimes obese patients is very difficult to measure, sir. Start from the mid-arm, you can see the phasic variation. Yeah. What I find over the years of 150 years fistula in a year, almost I covered 3,500 fistula. And that what I've learned, my fingers are the best ultrasound. First, I ask the patient to sit in my office, whether he is taking any drug which is causing bradycardia, like less than 50 heart rate, I will not take. More than 60, it's well and good. And no partial hypertension. Patient, if we see to that, there is not taken morning dose of antihypertensive. The moment you do the fistula, after patient getting out of the OT table, then stands up momently, it stop. All these things I'll take care. This is the first point. Second, artery assessment, as he said, what he has covered very nicely. And if the monophasic flow, I'm really worried. And any elderly patients, both the male and female, diabetic individual, chronic smokers, going to the brachial fistula, I always be a little worried about the distal part of the circulation. This always keep in mind, because I had one patient, critical limb ischemia, I had a trouble. Regarding the phasic variations, patients of our patients, most they are dyspneic and they cannot hold breath and things. What I suggest to the beginners as well as the people who are doing already, very simple point. You just trace the vein from the peripheral to the central across both the basilic and as well, whichever the vein you want to do. Cephalic the vein has got a lot of valves actually. If a patient has got a proximal stenosis, like a central vein, even if a patient has got a partial obstruction, the phasic variation may not give you an idea, but this point will give you an idea. Like I do a lot of echo. Whenever you have LV dysfunction, the mitral valve will not open. Like that, we can like the same phenomenon we apply here. You just trace the vein from distal to proximal. You see the collapsibility by just compression. That's one point. Another thing, the valve, how it when the flow towards the heart from the vein, it goes. The valve should approximate. It close touches the valve will touches the wall. Valve will touch the wall. That means the vein is opening nicely. If there is any kind of a proximal stenosis, the distensibility will not allow the valve to open completely. This finding, I find it extremely useful in a patient already on a left side catheter, right side catheter, whichever the way, and the patient's already on catheter if I'm going for a fistula. So rather than a phasic variation, sometimes our patients cannot hold breath and they're always dyspneic. So many times I miss it, but this finding helps me a lot. It's only complementary finding, but otherwise, he has covered everything nicely. And well, it was clinical examination very important, sir, because I've you started doing fistula much earlier than me, but I'm doing last 20 years, and so that now the people are more worried about. I mean, without mapping, they will not touch. But I was doing fistula without vascular mapping, almost 90% success rate. But now it gives me more confidence that before doing a fistula, if I do mapping, 100% I'm sure that I'm going to be successful. Otherwise, on table I'll judge certain things. But now the era of all medical legal issues and other things, we have to teach the younger generation with the scientific gadgets and other things. So mapping is important, and a lot more to be learned over the time of experiment doing fistula. The person doing fistula, I mean, if mapping and doing fistula will have more comparison than reading some report from radiologists and doing a fistula. It makes a lot of difference. I think Raj touched it nicely, and this is one point I added, so the phasic variation point.
Yeah, plus AV fistula is done by nephrologists. When I met Tushar and people in Asdin, I mean, we don't tend to keep a record of the cases we do. We know that we have done a fistula and it works once you come out of the theater, and I think you think it is success. So that way it will be 99 to 100% success. Only 1 or 2% will not work once you come out of the theater. So when I try telling this to people, and when they hear from them that their results are less than 60% success rate in fistulas, then I realize the difference, because when you just consider the success when you leave the theater, and the number of patients who are successfully cannulated after 2-3 months, when you take up for dialysis, I think there is a lot of variation in the numbers. So for that, I think this mapping and assessing would help you, pick up cases which will ultimately succeed. So it is not merely, fistula with bruit at the end of the surgery.
Bala, can I add a point
Yes.
to what you just said? Yes, at least here, and you guys are familiar with the literature from here, and you mentioned about the mapping and the success or primary failure rate. I mean, the biggest study from NIH, the Dialysis Access Consortium study, where all of these points were considered. Every site was using mapping, and even then, the primary failure rate was about 60%. So yes, I know. You guys have. I mean, as nephrologists, when you do it, you have a much higher success rate. But I think it would be really nice if somehow you can collect that data and publish it. I mean, for 20 years, if you've been doing it, and if your failure rate or primary maturation rate, failure rate is less than 10%, I think that's just phenomenal, and that really needs to be highlighted in literature.
Yes.
I know it's difficult with the clinical time and the resources. It's hard, but I think collectively, at least now that you've started this forum, maybe one of your objectives should be to start collecting data and have a central repository where people enter in their, as soon as they do their studies, they enter in and provide maybe 4 weekly or 3 monthly, some kind of an input.
And any other questions or comments for the other talk on catheter dysfunction? Dr. Lobo, you want to give any final comments on that?
No, I think I made my points earlier in the discussion in between the two talks. So I think, again, the same thing where catheters, we are all concerned. In our unit, for instance, a few years ago, our use of catheters was about 10%, and now it is 22%. So clearly catheters are there to stay, and so we need to use them better. And what we are doing is to try and see why we are using so many catheters. That's one of our students' thesis topics now, and see how many of those catheter patients we can convert over to AV fistula. So that's important. And the other thing is monitoring. What Tushar just said about getting it down, documentation is where all of us fall behind. In busy times, we don't document, we don't collect. And something that happens is, which I've learned from personal experience, we tend to remember our successes and we tend to forget the failures. So that's why documentation is the most important thing, because then we'll get a true picture. That's all.
Yeah, otherwise there is a selection bias, and then you tend to keep thinking about all your successes, like you said, Rally. So doing it more scientifically would give a much clearer picture.
I think we'll take it from you and start creating. There are only few of us doing fistulas. We can have a protocol and the definition of primary failure, secondary failure, and all that. And I think we'll try to collect data and get a realistic picture of our prowess or
I think you have this now. Just create a cloud-based Excel sheet and just keep entering it. And maybe at some point you will find somebody who will be able to analyze it, maybe 2 years down the road. So,
because precisely, I was also, having a great false thing about my thing, because I was confined to only looking at the result at the end of the surgery. So let us see, we'll work on that and come back to you with Indian data.
Yeah. And the definitions, well, the definitions are all there. You just have to pick up the NAVEX document from seminars in dialysis, and there's a uniform definition for everything. Primary failure, what is clinical success, what is clinical patency, all of that is there. There are about 50 definitions over there.
Right, we'll allot somebody, and I think we'll start collecting data from ourselves. Okay, I think Sampath. Yeah.
No,
Hemant?
I'm dumbfounded by the presentation and the discussions. So I'm just a listener now. Yes.
But I'm not getting juniors and freshers asking questions or clarifying things. There is no questions in the chat box either. But the website is on, and I encourage people to, at least your problems will be taken up for discussion in the forums, and some seniors can answer them definitely. Especially today we discussed about different people having their own regimens for declotting, and we'll have to learn from each one of them. I think that's the way we grow. It is not always from books. So let me thank everyone, Dr. Lobo, Dr. Tushar, Dr. Hemant, and Dr. Rajarajan, Dr. Venkatesh, and all the people who came for the meeting. But I wish more and more, feedbacks for me, so that, and what I'm thinking is, after a few meetings, I would make somebody the sort of to take up one meeting and consider the topics, arrange the speakers, so that way that will involve wider, because I wouldn't know who are all doing good in different places of the country. So I'm thinking something on that line. I think Hemant and Lobo from North should be able to pick up more people who are active in international knowledge. Thank you once again. Yes.
Can I ask one question, JB?
Yes.
With so much interest now there, have you identified sites where people can train?
Sites
I know
where
I know you have been training people, but I get requests from India, and I know there are so many people doing these procedures. So why should they even go to another country and try to learn? I think there is enough opportunity within India now. When we first met, I think 15, 20 years ago, it was new, but I don't think now. I think India is way up there. I think there are so many places, so many experts out there. There's no reason for the new generation to try and look for training sites outside India. I mean, within India, they will get hands-on training. If they go out, all they'll get is observer's position. I think it doesn't serve the purpose.
But remember, Tushar, you are considering some form of accreditation to centers which can give training, because there is no system here.
I think CMC Vellore has started a course which is accredited.
Yeah. So
Dr.
yeah,
Santosh
there should be more centers who are accredited, and there should be a system how we should be. I think they went through the Madras, MGR University here. If ISN itself, or I don't know how it works in US, but I've been trying to ask people from various places the methodology where we can accredit centers, so that anybody trained in that center would be ethical. Because one of these meetings, it is going to be on the problems how people face trying to do interventions. It will be there in the next few months. So that is the time we'll be able to discuss, and there are very funny situations where they are objected by the surgeons or the hospital management. I know one boy from Vellore where he was given quota. You can do only radial AV fistulas, not elbow, and only 2 PD catheter insertion per month and things like that. So how to get around all this? I think we need to put our heads together, and we'll allot a meeting for such discussions in one of these months. Yes, thank you. Then I think we'll stop here.
Yeah.
And I'm glad so many of you got involved today, and we'll call it a day. Thank you. Thank you, Tushar.
And
Thank you, sir. Thank you.
Great seeing everyone.